This conference will now be recorded.
Okay, Margot, go ahead.
Okay, thanks, Nicole. Welcome, everyone, to today's Framing Rural Health Value webinar on workforce. My name is Margot Kolseth, and I'm an information specialist at TASC. Before we get started, as a reminder, all phone lines should be muted by default. Please press *2 to unmute your line if you'd like to ask a question. You may also use the chat box to communicate any questions or to let us know if you're having trouble hearing the speakers or any other technical difficulties. I'm actually getting an echo right now. Is anybody else getting an echo? Nicole, I wonder, is your line muted?
My line is muted.
Okay.
Margot, unmute your line again, please.
Okay, is that any better? No, I'm still hearing an echo.
How about now?
Testing? No, still echoing. I can hear myself. It looks like there's... Okay, everybody hold on just a minute. We'll see if we can fix it. Okay, can you hear me now? And the echo's gone. Kenny says I sound like Lou Gehrig. Okay, Sally says it's much better now. Better. Okay, good. Hopefully it's better. I'm going to keep going. Okay, so I'll just briefly repeat what I had said. I was just welcoming everybody to the webinar today. I'm Margot Kolseth. I'm an information specialist here at TASC. And as I was saying, *2 to mute or unmute your line. And hopefully if we have everybody muted except the one person who's speaking, we should be able to avoid the echo problem. So *2 if you do need to ask a question, and then *2 to unmute your line again. So please let us know if you're having any technical difficulties. You can type it in the chat box as well. That's easier. And Nicole, I don't seem to have rights to advance the slides. Bear with me one moment. There we go. Okay, so in review, here's the Performance Excellence Framework we are talking about throughout this webinar series. The webinar presented by Terry Hill on May 21st covered leadership and strategic planning as represented by the red and orange rectangles on the upper left of the diagram. And today we're focusing on workforce as shown in blue in the upper right. And then in the upcoming webinars, we will continue to cover the rest of the components in this framework. So our blueprint for value involves leadership alignment, vision and strategy, partnerships, care coordination and community, use of data and information, having a change-ready and adaptable workforce, highly efficient business-oriented processes, all leading to excellent performance and success in a value-based system. For our purposes today, we are going to talk about workforce as it relates to the FLEX program and FLEX activities. So we will take a much broader approach to the topic of workforce and its role in healthcare reform and a value-based system. So today's learning objectives are to comprehend the need for a critical access hospital workforce that is change-ready and adaptable, including use of new types of healthcare teams or technologies, to understand the value of a culture within the critical access hospital that is patient-focused and customer-driven through the use of lean performance improvement and hospital consumer assessment of healthcare providers and systems, or HCAP findings, and to recognize the importance in nurturing ongoing critical access hospital staff development, retention, and practicing at the top of licensure for excellent patient outcomes and care coordination. To be successful in the area of workforce, an organization must effectively promote a culture focused on excellence, implement an effective process to address staff satisfaction, effectively provide access to staff skill development, and effectively promote a patient-focused culture. And so these are some comments about workforce that came from a group of rural health stakeholders at a Critical Access Hospital Performance Excellence Summit that was held last year. Some of the comments were, we are currently focused on personal accountability as a first step. Until we have supportive personnel systems that allow us to embrace and support change, it is not going to happen. Don't create panic, but you must create a sense of urgency. And storytelling and mythologies cause people to become more engaged with the organization, and it becomes the glue. Here you see our 3 panel members for today. I'm very excited about our speakers today. They have just an extensive knowledge about this topic and some really exciting programs and expertise to share with us. So just before I get started, I'll let you know that at the last minute we did add some slides for Mary Ellen Pratt's presentation. So if you received an email from Nicole Clement earlier today with a copy of this presentation, those slides are not included. But this call is being recorded, and as always with these webinars, within a day or so, we will have this recording available on the TASC website along with the current full version of the PowerPoint presentation. So what I'll do is I think I'll start by introducing Mary Ellen Pratt, and we'll have her speak, and then I'll introduce the other 2 and have them speak. And we'll kind of hold off until the very end and open it up for questions so that you can ask questions of any of our 3 speakers today. If there's something you're thinking in the meantime that you might forget or that you want to make sure gets in there, please feel free to type any of your questions in the chat box as well. So welcome to all 3 of our panel members today. They have generously offered to share their expertise with us. And starting with Mary Ellen Pratt, she earned a Master of Health Administration from Tulane University School of Public Health and Tropical Medicine in 1986. Upon completing her master's, Ms. Pratt was an assistant administrator at Tulane University Hospital and Clinic from 1986 to 1992. From 1992 to 2004, Mary Ellen was an assistant administrator at Thibodaux Regional Medical Center in Louisiana. In 2004, Ms. Pratt returned to academic medical centers by serving as the administrator of University Hospital and Clinics, Holmes County, owned by the University of Mississippi Medical Center. Since 2007, Mary Ellen Pratt has been the Chief Executive Officer at St. James Parish Hospital. While at St. James Parish Hospital, Mary Ellen has been the recipient QHR CEO Award for Most Increased Admissions 2009 and QHR CEO Award for Best Performing Critical Access Hospital 2010. In 2012, she received the Community Leader Award from the River Parishes Chamber of Commerce. Mary Ellen serves as a member of the AHA Small and Rural Hospital Governing Council, a board member for the Louisiana Rural Health Association, and a member of the Office of Rural Health Policy Rural Health Issues Group. Mary Ellen will be sharing her expertise with us today on the topic of workforce as it relates to culture, use of lean and HCAP findings, employee engagement, retention, leadership and staff development, and aligning employees with patient satisfaction. We welcome Mary Ellen Pratt. Mary Ellen, when you're ready, go ahead and press *2 to unmute your line.
All right. Can you hear me? Good.
Yes.
I'm going to talk a little bit today about how we are driving performance at St. James Parish Hospital through workforce engagement. And just to set the tone, at St. James, our most recent employee satisfaction survey, which we did in 2013, we're going to be doing another one in the fall of this year, But we actually ranked in the 93rd percentile in the Avatar's national database on engagement. So we're doing a really good job with engagement here and scoring well above the national norms with regard to how the employees perceive their involvement in the organization. So I'm going to share with you some of the things that we have done and why I believe our scores have been as high as they have been. First thing that I want to go through is why engagement? Why is everybody talking about engagement, and what is different about engagement versus just having satisfied employees? And the real difference is kind of this comparative I have here is that a satisfied employee is just doing their job. They are concerned with what makes them successful and what is important to them personally in terms of their commitment. An engaged employee, though, is one that is doing their job not just to do their job, but to go above and beyond, to really be, wanting to do the best that they possibly can. They're also more interested in not just their own personal success, but also in the success of the company. So they're helping you drive your results. And then you've got this balanced mutual commitment. And it does go both ways. You've got to be committed to your employees if you expect your employees to be committed to you. So, what have they found from research? And engaged employees really do drive results. The data shows that 250% more likely these employees will be recommending improvements in your organization. They're going to be, wanting to show you how they can improve the workplace. 480% more likely or more committed to helping the organization succeed. And they're 370% more likely to recommend their organization to somebody else. So this is a key driver to our organizational success. So what I've tried to do today is kind of organize some of the things that we've been doing here in a framework that would make sense. And what are the drivers, in a sense, of what drives our engagement at the hospital. And I really do believe that the first thing and the most important thing is values and behaviors. And values and behaviors is what drives your culture. And then you've got to be able to execute change and be creative with what you're doing with employees and engaging them in that change. But you also have to train them. You have to really be focused on what they need to be able to do their job and what you're asking them to do. And then, you definitely have to have accountability. And that's the part that I know sometimes we feel uncomfortable about, but you have to have accountability. But when you do that and you focus on the things that are important and you reward those behaviors and those things that are important, you're really, really going to drive your engagement. So that's how I'm going to kind of go through these things. So, we talk a lot about culture, and, it becomes, what is culture? It's this nebulous thing that nobody can see. It's just kind of a feeling that's out there. And the way, I have defined culture is it's a collection of values and norms that are shared by a group of people. So it's what you believe is important in your organization. And so I see that as our values and our goals, what we're trying to do, what is important to us. And we live by those values, and we are hold our staff accountable to those values. And then they become a real thing that you can see act out in the organization. But you also have to engage employees through purpose and passion. And that's one thing I say, that in healthcare we are fortunate to have a lot of purpose for what we do. We make people feel better. We can cure people at times. There's things that we can really embrace and feel good about our jobs. And most people that have entered into the healthcare field want to do good. So we've got a lot to be passionate about. I'm always grateful that I'm not in a business where I'm, producing widgets, because I'm not sure how I would get real passionate about my widgets, but I can certainly get passionate about the help that we provide people in times of difficulty. And so once you get that passion, then employees are going to feel like they have worthwhile work that they're doing. And then you can shape that worthwhile work in the behaviors that they do. And that's what's driving the service culture. That's where we get the HCAPs in our organization to be scoring so high. And then when you do all that stuff right, you get the results. And because that's what's driving the organization to succeed with its goals well, with our goals. So how do we create values in our organization? As I said, that nebulous thing of culture. How do we drive that? The way I see that is that you start with what the standards are that are important to you, and we have standards of performance that have been developed by a team of employees. Our top performers were set aside and given the charge of developing what are the attributes and the behaviors that we think are important that every employee needs to live by. Those standards of behavior, I can tell you, have been in place for a long time. They precede me. I've been at the organization 7 years, and they precede me, so they were probably there around 10 years ago. But they're basic, and they're easy to communicate, and we really hold people accountable to them. But it also starts with, making sure you hire the right people. And we use behavioral-based questions in all of our interviews. It's not so much about, do you know how to do the job? The skill part is important, but we really want to make sure that they have the values that are important to us in terms of their customer focus, their team orientation, and those kinds of things. But then we also tie it to our performance evals because, it's one of those things you've got to really walk the talk, and you say these things are important, but are you really evaluating your employees based on these behavioral standards? And we do. Our employee performance evals ask questions, or they're scored according to their attitude, according to their teamwork, according to their customer focus, cultural sensitivity, those kinds of things. So the next thing, I want to talk about is, how do you execute change? And in healthcare, my gosh, the pace of change is at warp speed at this point. But certainly you've got to communicate urgency. And a lot of times you can use data to communicate urgency, and I think that really, really helps. But you also have to give them the skills to be able to make the change that you want them to make. And this is where we do a lot of staff development and things like that. But these are just a couple examples of some of the things that we have put into place that has helped our HCAP scores. One is called AIDIT, where we make sure that every employee, when they're coming up against a patient or even a visitor, that they acknowledge that person and call them by name and give them their name, that they introduce themselves, that they explain how long they're going to be with the procedure or whatever that they're going to do, explain what they're going to be doing, and then make sure that they thank the visitor or the patient for choosing us. So those are some of the things that we put into place. We kind of make sure that every employee is following that whenever they're in with a patient. Another example is hourly rounding and how we communicate that to our staff to make sure that we're focusing at least on an hourly basis on what our patients need when they're in-house in inpatient. The other thing we do is scripting, and scripting has a really powerful way of making sure you get consistency in your organization for the things that you want. We always talk about privacy and how important that is. Well, what does that mean? Well, we probably close the curtains and pull up the covers on people all the time, but we don't always tell them that, hey, we're doing this because I'm concerned about your privacy. So we basically kind of hardwire those scripts. One of the things that we say before we leave a room is there anything else I can do for you? I've got time. So we've done those kinds of things to execute change. other thing that is extremely important in any kind of change management that you're doing is involve your employees. We do that through our lean teams, and whenever we're doing a big process change, we always bring the frontline staff in. We educate them on what we're going to be doing, but then we solicit their ideas and their innovation. Employees who are able to contribute to their workplace are much more engaged. They feel like they have control over their environment, and they give you really good ideas because they know their job better than we know what they're doing. So that's key to it. The next thing, though, and I kind of mentioned it in executing change, is that you've got to make sure that you're developing their skills as well. And, you know, sometimes it's as simple as just giving them scripts and coaching them on how to use those scripts. But other times it can be more complicated. I have a picture here of when we did some simulation training with actual some dummies that were pretty lifelike. And we were able to do some things that in a critical access hospital we don't get to see very often, but are very critical when they do come in. This is actually a pediatric code because we don't get that many kids, and you know, whenever you get a drowning victim, I think it's what we were doing a scenario here. That's always very scary for the staff, and it's something that we don't do often. So we use simulation on training the staff. We work with the university locally to do that. But the other thing, which is key, is leadership development. Most of the time we promote from within because we've got good staff, but we don't train them on how to be leaders. And this is a picture of how we do our quarterly leadership. We're actually got one scheduled for Friday. I was working on the agenda this morning, and we're going to be, you know, talking about competency training with our staff. We're going to be talking about our expectations in our monthly meetings and what we expect from that. There's going to be some structure to those agendas and how we expect all that to go through. But the purpose here is just that you can't expect people to know what they're supposed to do. You have to train them on what they should be doing. And so you've really got to focus on training. And it doesn't mean you've got to spend a lot of money and send people off to, you know, fancy seminars. It's about just sitting down and setting those expectations very clearly to your staff. We do these mainly virtually. If I have a speaker, it's usually a virtual speaker, and that's actually me standing there talking about something. And I always do a good bit of the training myself. But then, you know, we talk about accountability, and that is so key because there's nothing that's more disengaging to employees than to feel like people aren't being held accountable. I'm going to work really hard, but then my coworker next to me can kick their heels up and not do anything. That's very demotivating. So we really believe that accountability is important. And one of the ways that you drive accountability is through monitoring. And it sometimes feels like you're a big brother looking over people's shoulders, but it really is an essential part of making sure that things are happening. And I have an example here of just how we monitor our HCAP scores. And we produce that on a monthly basis, and we're tracking the numbers that we're wanting to see improved. And so the staff see that. It's on bulletin boards. It's posted on our intranet and all over the place. So part of it is you know, just monitoring what your numbers are and where you are. This LIM is our Leader Evaluation Management System. It's where we have put our goals in, our annual goals that we set, and then we cascade it so that each manager has their own set of goals. And it's a software system that they use to keep up with the progress on their goals. They have to put results in, they put their action plans in, and then I can monitor what's going on in the organization. And it's all about making sure that the goals that I have set for the board, such as, you know, reaching a certain margin, getting above the state and national averages for our core measures, or, you know, the 90th percentile in satisfaction, whatever those goals are, I have to get them done through my department managers accomplishing their individual goals. And so we have that, and it's very transparent, it's very public, and so, you know, it's a sense of holding people accountable. We also do a lot of rounding, and that's not anybody in my organization, that picture, but it shows people walking through the organization like we're rounding, but we round on patients, we round on departments, we round on physicians, we round on employees, we round all the time. I laugh and say we are a very well-rounded organization by the time we finish. But what rounding really is just validating that things are getting done. When I go talk to patients, I want to make sure that my staff are using the AIDIT tool when they come into a room, that they know who their nurses are, that they know who's the supervisor, and all these kinds of things that we have said we want to be done on a continuous and ongoing basis. So we round to confirm. There's that adage that, in God we trust, but in everybody else we have to validate. I mean, that's kind of the way it is, and sometimes it may feel uncomfortable, but it's a fact of life. And when you start holding people accountable, it's amazing how much alignment you get. The other thing as part of accountability is, as I said earlier, is that we just tie it to our performance evals. And when that really is putting your money, because we pay based on performance, where your mouth is in terms of what you value. And last but not least, of course, is rewarding and recognizing employees for the work that they do, and recognizing those behaviors that you want to see repeated in the organization. We do wows, we do thank yous, we do these posters, congratulations to staff for doing different things that are related to service excellence. But it really does make a difference. We send thank you notes to their homes, and write personal notes to employees. But these are the kinds of things that really, really makes them feel like they're contributing to the organization, and when they feel like they're doing worthwhile work, it doubles their engagement. So all of these things, I think, all work together. I don't think you can do one. You have to kind of do it all. But when it all comes together, there's a synergistic effect, and it has resulted for us in some really, really strong engagement, and also some really, really strong results in terms of our employee satisfaction, and our HCAP scores are always above the state and national average. And Louisiana is one of the highest states in the union in terms of HCAP scores. So that's a pretty tough mark to have. So we're doing really well with it, and it makes a big difference.
Thank you so much, Mary Ellen. That was some really good information. I jotted down several questions of my own, actually. And I think what we'll do and congratulations on your HCAP scores as well. I wanted to make sure to say that. Very impressive. So just for the sake of time, what I think we'll do is stick to our agenda and have our other two speakers speak next. And if you have questions, please jot them down or keep them in mind, and we will come back to Mary Ellen and have an open question and answer session here in a little bit, where those of you in the audience can ask questions of all of our speakers. So thank you again so much, Mary Ellen, for that. And up next, we have Cynthia Hardesty. She is the Vice President of Clinical Operations and Chief Nursing Officer at Charles Cole Memorial Hospital in Coudersport, Pennsylvania. Since Cindy joined the administrative team at Charles Cole 8 years ago, she came to CCMH with a master's in administration from the University of Notre Dame and 34 years of healthcare experience. Cindy worked for approximately 8 of those years as a nursing leader in med-surg, intensive care, and post-anesthesia care unit. She subsequently served as the Senior Vice President of Nursing and Patient Services in a large Catholic health system. Her experience includes team building, productivity management, organizational change management, and strategic planning. In addition to her role at the hospital, Cindy continues to provide consulting service to hospitals in the areas of productivity, nurse leadership coaching, accreditation, and strategic planning. She describes her most important work as, quote, reminding other staff that they really can make a difference. Cindy will be sharing her expertise with us today on the topic of workforce as it relates to transitions of care, care coordination, and practicing at the top of licensure. We welcome Cindy Hardesty. Go ahead with *2 to unmute your line when you're ready, Cindy. Cindy, are you there? We can't hear you. It's *2 to unmute your line.
Can you hear me now okay?
There you are. Yes, thank you.
Okay, I just gave you a great big long explanation. I'm traveling this week and I'm staying in a hotel right now, and of all things, their phone system went out today.
Oh,
so
no.
I'm using my cell phone, and I'm hoping that that works okay and that you can hear me all right.
Okay, we can hear you now, so fingers crossed. Thank you.
Good, thank you. I want to start out telling you just a little bit about our hospital. We are a critical access hospital in extreme north central Pennsylvania. And like the other critical access hospitals, we are a 25-bed facility, although I will admit to you that with observation patients, there are days that we exceed those numbers. We have inpatient med-surg services, OB-GYN services, and we are probably one of the last critical access hospitals in our state to offer OB services, which is not an easy decision to make, I have to tell you. In and outpatient surgery, we have about 8 surgical specialties to take care of our surgery department. Pain management, we have a 10-bed geropsych, a 50-bed skilled nursing unit that is housed within our hospital building. We have a full-service cancer center on our campus, radiation and chemo-oncology. We have 8 rural health centers that are located in the 2 counties and 4 or 5 communities that surround us. We have a DME company that provides DME in our particular specific area. We have a home care and hospice and a personal care home. So lots of activity going on at Charles Cole, and in some instances we are not the only providers of these services, but we are the only hospital for about an hour in any direction. I just wanted to take a few minutes to talk to you about our transition team and the work that they've done. Maybe mention briefly our ambulance and transportation solution, because I know that is a problem across the country. Mention briefly our medical home efforts, and then at the very end talk just a few minutes about our efforts to help the nurses to practice at the top of their license. Approximately 3.5 years ago, we pulled together a transition team. It was in response to begin with to the Partnership for Patient Community-Based Transition Team grant. And we found out about halfway headlong into that process that of all things, critical access hospitals were not eligible to apply for the grant. To say we were disappointed is an understatement, but we knew we needed that team, so we continued to move forward. That included representation from the nursing homes. There is at least one nursing home in each of the communities that we work with. And in some cases, there's more than one. We have a community pharmacist on our team, the area office of aging, our care managers, our personal care homes are represented. Our primary objective in coming together at that time was to reduce readmission. And at some point we realized that the home care agencies, the nursing homes, the hospital, we were all trying to reduce readmissions and thought perhaps we could accomplish a little bit more if we were just working together. We saw in that first year a 15% reduction in our readmission rate, and we continue to have an all-cause readmission rate of about 8% compared to 13 to 17% in our Pennsylvania hen. That team has gone on to create a standardized transfer form that's used for all inter-facility transfers. They've also done some work to coordinate post-implementation. They rolled that out across all the facilities at the same time. They've standardized care plans for some of our chronic care diagnoses, including COPD and CHF. So from the hospital perspective, we've continued to work with the nursing homes and the home care agencies to plan the care for their advanced illness patients to try and keep them well and out of the hospital to the extent possible. Additionally, they've rolled out a communication system called Direct Communication, which is a secure system for communicating and transmitting patient information from provider to provider, maybe referred to as the poor man's HIE, or Health Information Exchange. This has reduced paperwork for us and allowed us to transmit significant portions of the patient record to facilitate their care in the next location. It's a much quicker process, less time consuming on our end. We're in the process of figuring out how to push a button in Meditech, which is our IT system, and just get the information to go without a whole lot of human interaction, which will be a great thing. I'd say the success of this team is probably based on the relationship that they have been able to build. The first meetings of that transition team were, people were a little standoffish, but we got them to the table around lunches once a month for several months. Each facility had an opportunity to introduce to all the others what they do, if they have a specialty service that they provide. We needed to get over the competitive nature everyone has and get them focused on information sharing and how can we help each other. That spirit of wanting to help each other helped them be successful. We started to see some real progress, and as I mentioned, significantly decreased our readmission rate. The hospital, at the end of that first year, probably about a year and a half, received a State Achievement Award for their work, for the work of this team. And we made a point of inviting the entire group, people who were employed by the hospital, people who were not employed by the hospital, to come and be with us when the award was presented by our State Health Association representative and one of our state representatives. So everybody got recognition for that. We've had some other success stories, some financial awards to different groups that participate on the team, not the hospital. And they have come back to the table and said, we want to share what we got and help the hospital achieve an outcome for discharged patients. We had an issue with people needing food. We don't have Meals on Wheels in our location. And our area office of aging got a grant for providing meals to patients in a certain time frame after discharge. And they came back to the hospital and said, we want to work with you and make this money available that we think will help keep your patients out of the hospital. The next thing I want to mention for just a second is our transportation solution. In our area, we have primarily a volunteer ambulance service. The time to transport a patient out of our ER has averaged anywhere from 3 hours to 8 to 10 hours. I can tell you in January we had 2 patients who spent as long as 21 hours waiting for transportation out of our ED to the next facility. This year we opted to hire 2 transport teams comprised of a paramedic and an EMT/driver. We've established agreements with the local services that if they can't provide a team of their own within 10 minutes of the time that we call and request a transfer, that they will let us use their rig, put our people on it, 1 paramedic and 1 EMT, and they will transport the patient. They bill for the transport, and then they pay us an agreed-upon fee to cover the cost of our team, maintaining our team. Our two teams alternate 7 days on, 7 days off. They're required to be in-house or on a transport 60 hours of the week. And then they are available on call to make other transports when they're not in-house. We've decreased our transport time. I looked just today before the phone call to see what our transport time was. In January, I think we were at 245 minutes for January, which seemed to be an all-time low for us. We implemented this program in late February, and this month we are at 90 minutes. In some instances, as I'm looking at the transfers, it appears that some of them get off in about 30 minutes, so it's a significant improvement for us. I think I mentioned rural health clinics in our network, and in January of this year, their corporate application and data was submitted to NCQA and accepted. This has been a year-long, at least a year-long process of pulling together data and information, making everyone in the medical group network aware of our desire to achieve recognition as a medical home or medical homes in each of our practices. The next step for us will be to submit data from a specific practice. We've already chosen that practice and submitted their data. They were recently accepted as a level 2 medical home. So we're now in the process of submitting data for all of our other RHCs. In order to make this move, we implemented during the same 1-year period of time an EMR in all of the practices. We added care managers that cover the network practices. And I think I mentioned we have 8 or 9 rural health clinics. And right now we're managing that with 2 care managers. Those care managers have helped with the implementation of the EMR. They do some specific work with a specific group of patients. We've focused on the diabetic patient as well as our patients who fit the advanced illness management model. And again, working with them to get them in for their routine care and helping them stay at home to the extent possible. We saw a significant reduction in our patients coming to the emergency department who were patients of our primary care network, and just by having the care managers start to follow those patients. In one instance, we had a patient who in a 3-month period of time, 90 days, was seen in our emergency department 53 times. And since we've started with the care management program, that individual's visits to the ED have decreased to 2 in a 1-month period, and we hope we can continue to see improvement there. I think it's important to identify that we've been through a very specific, well-defined strategic planning process over the last several years that's helped to get our leaders, our governance, and our community as well very focused on what our strategic initiatives are. The process began this year with, which is similar to other years, began with a dinner and a meeting with our, as I mentioned, our organizational leaders, board members, community members. This year we were divided into 4 groups, and each group reviewed one of 4 what-if scenarios based on the possible future of healthcare that addressed everything from the spectrum of healthcare paid totally by the government to healthcare totally funded by the patient, and then looked at that in relationship to the model of healthcare, presuming we would continue traditional healthcare as we know it, all the way to the other end of the spectrum. What about healthcare at Walmart or Amazon.com or healthcare.com? The outcome of that planning process led us to 5 strategic initiatives, which include something we're now calling redefining the H. but it really is intended to accomplish care coordination, patient engagement, and population health. And that's kind of evolved over time. We started out in our original plan 3 or 4 years ago. This section was called Culture of Excellence. It transitioned to accountable care, and this year it's redefining the H: care coordination, patient engagement, and population health. And then we have a section, an initiative called Operating Performance and Safe Systems, an initiative on people, leadership, and culture, an initiative on community trust, and the last one is ongoing planning in an unstable environment, which focuses on our evaluating and acting on our need to strategically align with a partner, advocacy for critical access hospitals in our state, and with the federal government, so those kinds of activities. Lastly, I wanted to mention our nurses practicing at the top of their license. The Affordable Care Act outlines some new healthcare structures, including a number of programs that have been developed to target improvements in quality, access, and value of care. And nurses can help with the transforming, but the out-of-date policies, regulations, and cultural barriers that limit our scope of practice have to be addressed. Our strategic plan has a strategy in it born out of the Institute of Medicine Future of Nursing report, which I'm sure you're all familiar with. It includes a focus on our RNs, our CRNPs, CRNAs, and DNPs practicing at the top of their license. The report describes how historically regulatory and policy barriers have limited nurses' ability to practice to their full scope. And then, of course, there are other barriers of high rates of turnover, difficulty that students have transitioning from school to practice, and last but not least, the group I'm falling in, the aging demographics of our workforce. Regulations defining the scope of practice vary from state to state. Some states have kept up with the changes in healthcare by changing their scope of practice regulations to allow the nurse practitioners to see patients and prescribe medications without a physician supervision or collaboration. Other states haven't advanced, and what nurse practitioners are allowed to do after graduation from the program can vary widely. Our strategic activities have included advocacy at the state and local level to promote the independent practice of the CRNP, the CRNA, and the DNP. And then we allow them, obviously, to practice to the full extent that Pennsylvania law will allow them to in our organization. Another barrier I mentioned was the high turnover rate associated with the transition from school to practice. We've struggled a little bit with the concept of the nurse residency program because we are so small, and we finally just dove in this year and said, no, we're going to put a plan together for our GNs. We have 10 new grads who started with us this week. What we're planning to do is allow them to complete their initial orientation, which is about 3 months with us. And then we will continue to meet with them once a month and provide ongoing support and mentoring and education, simulation training, just allow them to network with each other throughout their first year. We'll continue in the second year then with them quarterly meeting to continue education, mentoring, relationship building. We're hoping that it's going to significantly impact there's a transition into the workplace. We're going to end up with a better nurse at the end of that process, and hopefully we will increase our retention of them. And we've really got everybody focused on helping to make these new grads successful. During the rest of that year, we'll continue to identify and design new opportunities and structures for them as we see the success of this program. I just want to emphasize that none of the work that we do is possible without, as Mary Ellen mentioned, the engagement of our staff. We need them to support these initiatives and help us move them forward. We try to bring them in right at the beginning, seek ideas and innovations from them, and allow them to implement them. And we have seen that be very successful for the organization, as well as we're seeing it demonstrated in the outcomes for our patients.
Cindy, thank you very much for sharing that very valuable information. And congratulations on your decreased readmissions. That's very impressive. And I was also really interested to hear about your EMS transport and your care management program. I imagine we might have some questions about those. We're running a little short of time, so I'm going to charge ahead and introduce Carrie Balbo, and then we'll have some questions at the end. Carrie Balbo has been the Flex Coordinator and Rural Health Manager for the Maine CDC's Rural Health and Primary Care Program since November 2012. Carrie's career has focused on managing programs and projects in healthcare and education, particularly in the areas of program development and management, project implementation, successful cross-organizational and cross-departmental collaboration, and intercultural communication work. Carrie has a master's in public policy and management from the Muskie School of Public Service at the University of Southern Maine and a BA from Oberlin College in Russian and Spanish. Carrie will be sharing her expertise with us today on the topic of workforce as it relates to new and innovative types of healthcare teams and technologies. Specifically, she will be telling us about the Rural Veterans Health Access Program grant in Maine and how various entities are working together toward the best interest of the patient. We welcome Carrie Balbo. Star 2 to unmute your line.
Thanks, Margot. Can you hear me okay?
I can, thank you.
Okay, perfect. So I can speak very quickly. I've never been accused of being a slow talker. So just at a high level, I'm very humbled to be on this panel with Mary Ellen and Cynthia, who have far more experience than I have. But I did want to, Margot asked me to talk briefly about the Rural Veterans Health Access Program grant, particularly in how it pertains to care coordination and the use of Maine's Health Information Exchange, which is in Maine is called Health InfoNet, which is also the name of the organization that runs the HIE. So just at a high level, the three primary goals of the Rural Veterans Health Access Program grant that we were awarded last year is to use the statewide HIE to improve care coordination for veterans seen both by the VA and by non-VA providers. In Maine, as in many states, I'm sure, veterans, because of the rural nature of our state, veterans are often seen at non-VA locations. Second goal is to provide coordinated and collaborative support to VA providers for implementing HIE connection, and that is specific to, and I'll talk a little bit about this, but making Maine's HIE, the Health InfoNet, giving that connection to all VA providers so that they can see a veteran's health record when they're sitting there and see all the information that a veteran has seen, has in terms of their non-VA provider health care. And lastly, the final goal of the project is to make the statewide HIE records available to a veteran who's accessing their medical records online through My Healthy Vet, which is their patient portal, Blue Button technology, and so on. So in light of that, I should just talk a little bit about Maine's HIE, in that we are fortunate to have one HIE for the entire state that combines records from all participating providers into one single electronic personal health record. And fortunately, all hospitals in Maine are connected to Health InfoNet, including all of our critical access hospitals, as well as more than 400 ambulatory sites, more than 30 FQHCs. Recently, long-term care and home health agencies have come onto that. So as of the end of 2013, we had 88% of Maine's resident population in Health InfoNet, in the HIE. So something that we're very proud of. And so the idea of using that HIE to coordinate care is something that is what is going to happen in the Veterans Grant. And to be frank, I should sort of step back here and say where we're at with the Veterans Grant right now is still making those very, very specific technological, and this is where my subject matter expertise might break down a little bit. But in terms of technical stuff, that we're still connecting the HIE with the VA's electronic record system, VELR, and vice versa, as well as getting the HIE on VA and Maine VA providers, basically on their desktops. And so in all of that process, that's still ongoing. And as you can imagine, with current events, things are challenging at times working with the VA. But we've been successful so far. It's just going along, and there's just a lot of hoops to go through. But I wanted to talk briefly about care coordination, because what we plan to do for VA providers is exactly what's being done for non-VA providers who use the HIE now. And I have some examples that I can use for that in terms of how clinicians are using the notification systems that Health InfoNet has set up. And there are several events for a patient that notifications can be set up for any provider that requests it for their patients. And notifications can be linked to emergency room admission or discharge, inpatient admission or discharge, SNF discharge, and laboratory and imaging use. And so the idea is a provider can choose to be notified within their panel of patients. Whoever they choose can be notified when a patient is seen at another hospital, for example, or is discharged from a SNF facility. So I just wanted to briefly touch on, and I just have a couple minutes here, an example of a hospital care coordinator, care manager, who uses Health InfoNet, the HIE, for a lot of different uses and has found really great use for that. They, for example, have at this one hospital, they have their MAs use the portal as just a standard operating procedure for chart prep. And so when they're seeing a new patient, even if they don't receive records from a previous PCP, they build in that information by looking at the HIE. Medication reconciliation, lab results, imaging, and so on. And so the primary focus of that is care coordination, so that a provider does receive an email if their patient has been seen somewhere else, and they can really just track where that patient is. I won't go into that in too much detail, but that's really, and the benefits also really are around cost reduction in terms of workforce and healthcare and changes in healthcare. Using the HIE can reduce the chance of duplication for labs and imaging orders. If someone can go into the HIE and see that this patient has already had their labs drawn, they don't need to do it again. Particularly important in a critical access hospital where so many patients are transferring, that allows for non-duplication of efforts. This one care manager who shared this experience with me, in terms of high utilizers, and I know Cynthia spoke to that as well, one of the very first emails that this care manager had prompted her to check on a patient who had gone to the ER 63 times in the last year. And being able to bring that patient into care coordination really makes that person's care so much better, and also just saves everything in the healthcare system. And it's a time saver that things like CT scans and x-rays results are there in the HIE and can be used right away. So we're at 5 minutes before 4, so I think I'll stop. I think it's a very high-level idea of what we're doing with the HIE in Maine, and the idea is that will be embedded with every VA provider, as it already is with practically all non-VA providers, so that a veteran or anyone else who's being seen, that full range of their healthcare record is seen by that provider that they're sitting with. So by once we're completed with the implementation, the VA records are in the HIE, and that VA provider can see the non-VA information via the HIE. So I'll just stop right